Just so you know, it automatically records. Good afternoon, everyone. We'll give everyone a couple of minutes to trickle in before we get going. I feel like that's a reasonable pause. Okay. Well, as I already said, good afternoon, everyone, and welcome. Today, our CME offering will cover working with adult learners and will be presented by our very own Ms. Clair Collins. Ms. Collins is the Director of Academic Infrastructure and Professional Development here at SHSU-COM, and she is a two-time Bearcat alumna, currently finishing her PhD from the University of Houston in Higher Education Leadership and Policy. Ms. Collins has been in medical education for almost a decade and with SHSU-COM since 2017. Her areas of specialty include course support, academic technology, curriculum mapping, adult learning, teaching, and broad-based advocacy work. Without further ado, I hand it over to you, Ms. Collins.
Thank you, Ms. Browning, and thank you everyone for joining us this afternoon. I'm not sure what the weather is like where you are, but it has been pouring here all day. So with that in mind, there is no better time of day or type of weather in which to explore adult learning, because it is going to be a downpour of information that we have for you today. This is a very high level overview of working with adult learners. If you have seen any of our CME materials, you'll see that this is going to be a series that you'll have multiple interactions on how to integrate best practices into your teaching strategies with either residents or with medical students. And so this is kind of the kickoff for that series. So we're going to talk a lot about theory today, and we'll talk a little bit about some best practices, but really what this is meant to do is help orient you to working with adult learners. And with that in mind, our objectives for the day are that by the end of the session, you will be able to explain the unique challenges and opportunities associated with instructing adult learners and discuss self-directed learning strategies. Before we get started, I want to mention that I do not have any conflicts with this material. I am receiving no compensation other than my standard work title and salary, and I did not publish any of this material myself. Okay, so let's start first with just some key assumptions about adult learners. These are things that you probably inherently already know about yourself, but is helpful to go ahead and say out loud so that we know who we're dealing with when we're talking about adult learners. So our adult learners are motivated by their specific needs and their specific interests. And basically that means that these are the appropriate starting points for organizing learning and organizing materials for your learners. If the materials aren't relevant to exactly what they need to be doing or what they are interested in, and if the passion is yours alone, a lot of times what you'll start seeing is adult learners start disengaging from that material. The second thing we need to know is that their orientation is life-centered. Adults' orientation to learning is life-centered. Therefore, the appropriate units for organizing adult learning are life situations and not subjects. This is kind of perfect for you all, right? So in the role of a preceptor or even a residency director, we tend to organize things around different types of clinical scenarios, correct? So you're already leaning pretty hard into fulfilling that need to orient people to something that is very life-centered. These are things our students are going to naturally want to engage with. They naturally want to learn. They are tested on these items on the boards. So you're already ahead of the game there. The third thing is that experience is the richest source for adults learning. And again, that plays into really well into clinical rotations and residency because of how hands-on it is. The years 1 and 2 of medical school, right, are very classroom-based. We're not interacting with patients really. Maybe there's some standardized patients, some sim mannequins. We're learning a lot about biochemistry and those basic scientists, but that's not really the thing that gets students excited about learning. They want to be with you in the field. They are excited to come to you and to learn from you and have you share with them kind of what your journey has been as a physician and how you approach your day-to-day work. So adults also have a deep need to be self-directed. So the role of the teacher, your role is to engage in a process of mutual inquiry with them rather than to transmit your knowledge to them and then evaluate their conformity to it. So really, what this is saying is it's a little bit of a give and take, right? So if you ever find yourself in a situation where you feel like you're lecturing a student rather than having them engage and ask you probing questions about why you did something or how you did something or what even should be done in a particular type of situation, then you know that they're not engaging and being self-directed. We're going to talk a little bit more about the question how, what, and why, and self-directed learning a little later. And just know that self-directedness comes up a lot in this presentation and a lot in adult learning literature just in general. So the final thing that we need to keep in mind is that differences increase with age when we're talking about adult learners. So adult education has to make optimal provisions for differences in style, in time, in place, and in pace of learning. And really what that just means is as we get older, we have more defined preferences. We have learning styles that we tend to lean into more than others, and that's okay. And that sometimes the pace of the learning happens a little faster or a little slower, just depending on our ease and ability to take in new information. So we've covered about, what are our key assumptions. Let's talk a little bit about types of adult learners. There are 3 types of adult learners. There are goal-oriented adult learners, and really, truly, this is students who their education is used to accomplish really clear-cut objectives. If you think about people who really have their blinders on and they are just trying to get something done, that's a goal-oriented learner. Then we have an activity-oriented learner. So these are people who are motivated by other people that they interact with rather than being self-motivators. And then there are learning-oriented learners. And so these are people who seek knowledge for its own sake. And these are actually a hierarchy, right? So these students are starting over on the left, probably with goal-oriented or activity-oriented. And we have to figure out how to get them to learning-oriented. So based on conversations with faculty and staff, we've kind of got a mix of each type of student here at SHSU COM, and we're hoping to have them fully transitioned into learning-oriented by the time that they get to you all. However, there might still be some students who are in transition. So one of the things I always really think about is when we talk about having these mix of types of students, is it any wonder that a goal-oriented student and an activity-oriented student might struggle in medical education? A goal-oriented student will either end up with too many goals in the short term or be burned out trying to pursue the long-term goal, or even just be disappointed if they don't reach their goals. I'm kind of thinking of a student here that's a little bit of a gunner who comes in knowing exactly what specialty they want to match into. They put their all into being a subspecialist, a surgeon of some kind, and then they match into something else and they feel like they're a failure. And that's not the thing that should be driving us as people or as students in an academic environment. The goal is not the most important part. It is the journey, right? Like we hear that a lot in our own lives, appreciate the journey. And goal-oriented students don't do that. Additionally, activity-oriented students tend to be really competitive by nature or need lots of support from their peers. And this is often fine in a larger medical school setting where we have a couple of hundred students for people to compete with or to support other students, but it doesn't work in a day-to-day practice, right? Because what happens when you don't have someone to compete with? What happens when you don't have a student support structure to kind of fall back on? What you tend to see in those students who are activity-oriented learners is that they don't have a lot of inherent internal motivation. And so they kind of tend to stagnate a little bit. And so that's not an ideal place to be, which is why if you can teach someone to love to learn just for the sake of learning, they tend to be much more successful. They know how to be both goal-oriented and activity-oriented if the need should arise, but they don't have to be that all the time. And the learning-oriented students tend to have much, much better outcomes, much better mental health, and also much better physical health. So this is kind of where we come into play. So if you're ever looking for some reading to do, you'll notice that a lot of the citations I'm using are from like the early 1900s and the 1970s. These are kind of the seminal works of adult learning theory and approaches to adult learning. Every single thing you ever read about adult learning is really built off of one of these foundational theories, and they have not changed that much over time, even as we've produced new models and run different experiments and taken more quantitative and qualitative looks at these types of students and the research surrounding them. Everything kind of comes back to them. One of my favorites is tough, the 1979 role of the teacher, because these are the things that if you're looking to make an impact in a student's life, in a medical student's life or resident's life, these are the things that they need to thrive. And as long as they have these things, you'll see good outcomes in your courses and in your programs. So the first is something the students carry. It's they have to feel a need to learn. If you have a student who is disengaged with the process, who is feels like your subject matter is unimportant, they're going to get a lot less out of that learning experience. It is not up to you to really drill down into their motivation for wanting to learn. This is something the student has to bring to the table themselves. So you're not responsible for that. But what we can do is provide a learning environment that's built upon physical comfort, mutual trust and respect, mutual helpfulness, freedom of expression, and acceptance of differences. This is something we can supply. I know that sometimes hospitals or clinics are not, the environments are sometimes not physically comfortable, but even sharing with a student something small like, well, because I stand all day, I went ahead and got some inserts for my shoes and now my back doesn't hurt. Those things are helpful and they seem small, but they build trust with the students because you're kind of sharing with them your pro tips outside of even medicine of just you as a human. How do you get your work done and how do you maintain your comfort while you do it? Again, they need mutual trust and respect, but I want to be very clear about this. The mutual trust and respect is based on the levels at which you come into the relationship. Students do not expect to have the same level of trust and respect that you would give to a colleague in the field. There is an understanding that these are not fully trained physicians, these are student doctors, and that your level of trust in them applies only to their role as a student, and that your expectation is that they should not go beyond what a student should be doing. But that trust and respect, as long as you can trust that they are here to learn, and you can trust that if you give students something to learn outside of a clinical setting, that they will do it, then you're really kind of good to go. And I will tell you honestly, based on our interactions with students, they're going to come into this respecting you already. You're not going to really need to earn your respect, and they will largely trust you. They're going to trust what you say. If at some point in time a student questions you and says, well, why this approach? Or I've previously read that X pharmaceutical works better than this other thing. That's okay. They're here to learn. And so you can ask them and say, hey, go research that a little more for me. Maybe there's an opportunity for you to grow your own personal best practices, but maybe the student is reading literature that's old and you're more up to date on these practices. It's absolutely okay to correct them along the way and for them to ask tons of questions, because they will. And that's where that feeling of mutual helpfulness comes into play. It's a little bit of a give and take relationship that you're establishing here, right? Students want the information that you have, but also you can send them to do research for you so that you're not bogged down in reading. If one of the best things about having students kind of at your beck and call is if you've ever been bogged down in CME, you're trying to read up to date to stay abreast of like the best practices in your specialty, then these students can start doing some of that load for you and give you just brief overviews and even kind of have conversations with you as you walk down a hallway about things that have changed in the last month or the last year. They're wildly helpful with things like that, and they want to provide that type of feedback for you because that establishes that mutual helpfulness. Freedom of expression is important. Remember, I talked about students needing to be able to ask questions, and that's what I really mean by freedom of expression. We want to make sure that when we're working with students, we are engaging them in the academic learning environment, that we aren't shutting down their curiosity. Questions are fine if you don't know the answer. That's okay. You're not expected to be the expert in absolutely everything that you're teaching. It's totally fair for you to just go ahead and say, you know, I don't know the answer to that. So why don't you go look it up? Like, come back to me in a day, come back to me in 8 hours and tell me what you found about this so that we can discuss this. And then just an acceptance of differences. And that is a personal thing, right? We just have to accept that we're all a little different and we all have different needs. And if you're comfortable with those things, then you're going to provide a really good learning environment. So the third thing that we provide is the goals of a learning experience being aligned with your own individual goals. So we're already doing that, right, by virtue of what clinical clerkships are. And so students, their goal is to be a physician. And what are you teaching them how to do? You're teaching them the first kind of clinical application and having the first clinical experience on like, how do I actually do this? What is it like to interact with patients? What is it like to work with EMRs or EHRs? What is it like to be part of a healthcare team? This is their first true interaction with that. So you've already done it. You know, just by virtue of being who you are and being in the setting you're in, you've already fulfilled this third goal. The fourth one, again, is a learner-focused one. So the learners have to accept their share of the responsibility for learning, and they have to be actively engaged in the learning process. I put a backpack here, right, because I always think of this process as being filling your metaphorical backpack full of books, or in our students' case, their laptops, so that they can just Google their hearts away and look up, go out to PubMed and find the latest literature. But the learners, you're not the end all be all for them. And what I mean by that is they have to be willing to go and do some of their own learning. This is something we are teaching our students right now. I mentioned earlier, we're going to talk a little bit about self-directed learning, and this plays into that a lot, that there are only so many hours in the day that you can spend with our students. You all are busy people, busy professionals. The expectation on our end is not that you teach them everything that you know. It is that you guide them through their clerkship and provide foundational knowledge so that then the student can identify their own gaps and seek to fill those gaps on their own and in their own time and at their own pace. So you're not responsible for everything, and the student should be engaged in that process. The fifth thing, and again, we provide this, is that the learning process is related to and makes use of the experience of the learner. The best way I like to think about this for you all is just patient interactions. So really going through and saying, you know, when we are talking to X type of patient, it is important to look through this lens. This is why I rendered this type of diagnosis. This is why I presented this case. This is why I prescribed this type of medication. Really unpacking your thought process with these learners helps a lot. Again, it also builds on that mutual trust and respect, right? But it helps the learners know why they're in this setting, what they're meant to do, and how they accomplish their goals. And the final thing is that learners have to have a sense of progress towards their goals. So essentially, this is fairly straightforward for your group because our learners at the end of your core clerkship rotations will take an exam called a COMAT. And so as long as students feel like at the end of this core rotation that they have enough foundational knowledge to successfully pass that COMAT, then you're in really good shape. And that's actually not something that is yours to assess, right? Like our team here will give you the information on these are the types of clinical experiences the students need to have. And as long as they're having some of those clinical experiences, they're really in very good shape. And again, I want to point out, when you're talking about what do adult learners need to thrive, you break it down into kind of two fundamental categories. There's the them column, and then there's the us column. And those are the things that they control. So that's the learners feel the need to learn, and that the goals of and they have to accept their share of the responsibility for learning and actively engage. But then we control the bottom three. That's the learning environment. We control that the learning experience are aligned with their individual goals and that the process is related to making use of the experience of the learner. And then we actually all kind of move together towards the learner's goal. Like the reason that happens in medical education, right, is especially in a program like ours, which is new, if a student is struggling to reach their goal, if they're not successfully passing COMATs, if they're struggling a lot with the boards, that reflects badly on the program, correct? And it's the same for residents. If they're not performing, it reflects poorly on the program. So we all want to make sure that the learners have a sense of progress towards their goals, because them reaching their goals is good for them and good for us, and ultimately good for the patients we're all serving. So we're going to talk a little bit about adult learning theories. I mentioned that a lot of this is really foundational, that we'll go more in depth on strategies in our next session. But I want to talk about the three theories that you really just kind of see all the time. When you're talking to anyone in education, whether that just be higher ed or in medical education, and they're talking about adult learners, you're going to hear these come up a lot. So the first one is andragogy, and then we have McCluskey's theory of margin, which is a personal favorite of mine, and then we have self-directed learning, otherwise called SDL. So these are the three learning theories that tend to get the most play. Andragogy isn't technically a theory, and it gets a lot of flack from scholars because it's a very Western approach to adult learning and also considered very white. The gentleman who writes about andragogy, his name is Knowles, has acknowledged as much and is a little more current in his works and has made some adjustments, but still, it's a good place to start for anyone who is new to adult learning. And so he kind of breaks it down into 6 steps of the learning principles. So the first one is that learners need to know. They need to know, again, remember what, why, and how. That will keep coming up. That's going to be a big theme. What, why, and how. If you can explain to an adult learner what you're doing, why you're doing it, and then how to do it, you will have a very happy adult learner. Then the self-concept of the learner, they have to be autonomous and self-directing. Again, self-directedness coming back up, but autonomous as well. One of the things I really like about working with adult learners, whether that be faculty, staff, or students, is y'all are a stubborn bunch. Have you ever tried to get someone to learn something that they didn't want to learn? It was because they didn't want it at that time. It wasn't relevant to them. You may be sitting in this presentation and saying, I know everything there is to know about adult learning. What am I doing here? That's your autonomy and your self-directedness kicking in. And I kind of love that. I love that adult learners have enough context in their adult lives to kind of prioritize what is important to them at any given moment in time. And we, as the facilitators of that learning, have to be able to explain to someone why this concept is important. Think about when you were a little kid, if you asked too many questions of an adult, eventually, what was the answer that you got back? Because I said so. Because I said so works great with kids. Eventually, they'll just stop asking questions, usually. But it doesn't work with adult learners. As soon as you just tell someone, because I said so, if someone were to tell you, if you asked a question and they said, because I said so, what is your immediate reaction? Does your back go up? I mean, I hate that. If someone just says, because I said so, my immediate reaction is, this person is not on my team. The next thing is the prior experience of the learner. What are their resources? What are the mental headspaces that they are in? If we can dig a little into that, then we have much better experiences. Some of that is as simple as knowing if someone is a little more introverted or extroverted. It's a simple thing, but it makes a big impact. For instance, I have a very extroverted personality. So I know when I am working with someone who is very introverted, I need to tone that down a little bit because it makes them more comfortable in a learning environment. And that's not a mental model, but it is a mindset that I put myself in as an instructor or a facilitator. Then we move into the readiness to learn. So it has to be life related, a developmental task. Don't ask a student to start stitching things if they've never seen a stitch before. I mean, ours will have seen some things, but don't get too far out ahead. Make sure that the students are coming into the learning environment where they should be. And it's okay to take a quick assessment of your learners, ask simple yes or no questions. Have you ever done this? Have you ever seen this? Have you ever interacted with this kind of patient? If the answer is no, then you know that you need to go in with what we would call a base level 1 knowledge. Assume that your learner knows nothing. That's kind of what I'm doing with this presentation, right? I am approaching this from the theory that no one has ever given you any actual training on how to work with adult learners. And while some of you have probably received a large amount of it, it's not fair for me to enter into a generalized environment with a variety of learners and make the assumption that everyone is starting on the same page. The next thing is just the orientation to learning. Be problem-centered. Is it contextual? Problem-centered is easy to this, right? The orientation to learning, our students are bringing that with them. They're already oriented to this learning environment. We've prepped them really well for you all in their years 1 and 2 of medical education. And they actually do kind of like a pre-clerkship rotation with us here in-house before we ever send them off to you. So they should be well-oriented and prepared to step foot in your clinical environment. And the final one is a student thing, right? We talked about the motivation to learn. This shows up a lot, right? If an adult learner doesn't want to learn something, they will not. They are very stubborn. Our students are going to see the intrinsic value in what you are teaching. So please do not worry about that. They're going to know. The next theory I'm going to talk about is McCluskey's theory of margin. This is one of my favorite adult learning theories. And it's because it talks about the concept of power and load. And what it is power is the thing that gets things done. It's the thing that allows for learning to happen. It's all of the resources and positive things that you have in your life and a student has in their life that help them balance this thing called load. Load are the outside things, the distractors, the things that keep you from learning. And this is what that can sometimes look like. So I've used a bunch of examples here that are kind of like things that we would think are obvious and things sometimes we're not thinking about when we think of load. So if this is an equation, and we want it to be balanced, or we want it to even be tipped towards power, sometimes one of the things we see is a student is being weighed down. Their load is maxed out. They have a family wedding coming up. There are a bunch of exams they have to take. Remember, I mentioned the COMAT. At some point, students are going to have to go and take the COMLEX USA 2, and that's going to add a stressor. Maybe they're trying to review some biochemistry and that's stressing them out. They've got rent due because even though they're students, they still have to meet these monetary obligations. And then they feel like the only power they have, the only thing that's helping them get through all of this is family support and friends. Well, that's an unhealthy student. And so if their load, if this scale is tipped towards the load, they're not producing any power. So more limited learning is happening. But if we concentrate a little bit on stacking the deck, right? If we introduce things like advisors and learning resources, how to go about things and do things quicker and build kind of those mental muscles that make learning easier, we start seeing these things even out more. And then eventually the hope is they tip the other direction. And that's one of the things like a positive learning environment do, right? Is if you provide a positive learning environment for our students, then they will have the ability to learn. You're not required to balance everyone. You're not required to put all of the power on this, but it's something to know, because when you start seeing students struggle in an academic environment, a lot of times it doesn't have anything to do with their ability to learn or how smart they are or if they're engaging in the material. 9 times out of 10, when we're talking about medical students, it is this. It is that their load is so extreme, it's so out of whack that they can no longer perform. And that's a problem. And we have to give them tools so that it starts tipping more to power so that they can start performing the way we want them to again. So finally, I want to talk a little bit about self-directed learning. It's come up at every single stage. And self-directed learning, right, is probably something you've heard a lot about in like the last 10 years. It's really taken over the med ed world. It is in COCA standards, it's in LCME standards. Every medical school in the country is being asked to supply self-directed learners by the time they get to residency. And that is tough. And here's why. So when students come to us out of undergrad or even a master's program, they're used to a model that we sometimes call sage on the stage. And that is the teacher is the center of the universe. The teacher enters the classroom and the students come in and all the teacher does is teach them, right? It's a classic lecture scenario where the teacher knows absolutely everything and is meant to just relay all of that information out to the student. But what the student doesn't see is behind the scenes, what has prepared the teacher for that environment. And this is classic pedagogy, right? Students aren't seeing the resources that the teacher has engaged with, the support that they have from staff members like me, or their own personal training. And they're using that training, right, to then push information out to students. But that doesn't make students learners. That just let students regurgitate information. That is a very base level approach to education. So medical education has gotten away from that, and we're pushing towards something called self-directed learning. And there's friction around that. And I'm going to show you something that would tell you why. So if this is what classic pedagogy looks like, this is what self-directed learning looks like. Look at what a mess that is. So self-directed learning puts the students at the center of this. So right on the far left is where they start. And then they have to figure out, how do they get aligned with the training they need? Where are these resources? They have to individually go and find all of these pieces to themselves and see where the teacher is in this. The teacher is way far out on the right side. And that is because if someone is self-directed, the teacher is an expert. The teacher is not the source of all knowledge. There's someone you go to when you have 95% of the information you need and you're stuck somewhere, or if you're just wanting to validate your findings, right? And that's what we want to get our students to. None of us expect you all to be able to teach a student every single thing that you know. This is a two-way street. A student has to come prepared with some base level knowledge and not enter into your clinical environment with no knowledge. That's not acceptable to us. The students know that it's not acceptable as far as we're concerned, and it's not an expectation that we have for you in the clinical environment. The students should come prepared. They should have done enough background reading. And remember, they have other students to use as resources. So self-directed learning empowers the students to kind of take all of these seemingly disparate pieces of information and training and support and resources and push them towards learning, with the teacher playing a smaller but very important role. And one of the reasons for this, right, is eventually students aren't going to be in an academic environment anymore. They're not going to have a teacher holding them accountable, or a preceptor holding them accountable, or a co-mat holding them accountable. They have to, how do you do this in your own practice, right? You stay up to date. You keep engaged with the best practices in your own specialties. You attend a CME lecture just like this so you can learn more about adult learners. That is self-directedness. And students really struggle with this, right? Because this is easy. This is easy. This is fast food. This is me asking you to eat your whole grains, and no one wants to do it, right? But it is the thing that will keep a student mentally healthy and academically engaged. Self-directed learning. So with self-directed learning, there's an interactive model for self-directed learning. It's been around a long time. And it has really never changed. And the idea behind it is this: students have to be ready and they have to have autonomy. That's kind of the thing that describes self-directed learning. So essentially, students have to be able to answer these questions for themselves. Do you want to guess what the questions are? How, what, and why? That sounds familiar, right? So these are the questions you're answering for the students. When they ask you questions: how did I do this? Why did you do it? What are we even doing? But eventually, if they are self-directed learners, they have to be able to answer those questions for themselves. And your job is not to have the ability to answer every question for them, but to help them engage in how to answer these questions for themselves. Sometimes it's just watching you, right? Sometimes it's asking lots of questions. Sometimes it's you assigning a reading. All of those are great strategies. You should engage in all of those strategies with our learners. They will accept that from you. And you're allowed to set boundaries on, hey, that's enough questions for the day. At this point in time, what I'd like you to do is go and look at the literature and bring me back your findings. That is a fair thing to ask medical students to do. It's not up to you 100% of the time. So once we've started answering those questions, the interactive model for SDL kind of works like this. You know a student is self-directed if they enter into a task with motivation, and then they show that they have self-management and control. And self-management, what that basically means is when they are trying to answer a question, do they know where to start and where to stop when answering that question? Do they know how to not go down a rabbit hole? Do they know when it is time to shut a book or when it is time to come ask a question of you. That is self-management. And then they have to take responsibility for that learning. And this is where it causes friction, right? This is self-monitoring. This concept of self-monitoring is really, really difficult for students to make this jump throughout medical school. In my PhD program, I have years, right, to make this jump. And we're asking our students to do it basically in 2 years before they get to you. And that's a tough ask. And it's because they've been used to this sage on the stage model. They are used to a faculty member taking the responsibility for a student's learning. If a student didn't learn, it's because a faculty member didn't teach it well. That doesn't fly with self-directed learning. It doesn't fly in medical education either, because there is too much content for any faculty member to reasonably able to get through in 2 years with us here, and then 2 years with you all out in clinical rotations. It's overwhelming and it's not realistic. So students have to accept their share of the load. Remember, I said that there's that backpack that they all have to carry. If a student isn't doing self-monitoring, they aren't carrying their backpack. They have to take responsibility for their own learning. But if a student is doing those 3 things, then self-directed learning is happening. So to kind of wrap us up, I want to talk a little bit about where you can expect our students to be when they come to you all, and some things that you might look into doing as far as approaches. So to do that, this is one of my favorite models, Grove's stage model of SDL. What I like about it is it has scaffolding in it. If you don't know what scaffolding is, it's basically this idea that learning is a stair step. So you see this orange line on the screen, and it basically means to get from one step, you have to start at the bottom and kind of climb your way to the top. That makes sense to all of us, right? Kind of climbing up a mountain. So in stage 1, on the left-hand side, what we're seeing is the S represents the student, and on the bottom running across the T is the teacher. So when students come to us in medical school, they are a dependent learner, and our teachers are really the authority. They are looking for that just really classic lecture and drill, immediate corrections. The teacher is responsible for most of the facilitation of learning, and the students are holding the instructor accountable for that learning and their own growth. When you move to stage 2, you have an interested learner, right? And then the teacher kind of makes this transition into being a motivator. And sometimes this is called a salesperson. That's a little bit of what I'm doing here, right? My understanding is y'all are not dependent learners. You are not dependent on me on this information. And if I disappeared off the face of the earth, you all could figure this out on your own, because you're all smart, capable people, capable of self-directed learning. But our approach is, you are an interested learner, and it is my job to make sure that you want to learn what I have to give you. And then when they move past that, what you're going to see is the student's a more involved learner. And so they want to work in teams. They want to ask more questions. They want to engage in their own learning and bring new ideas to the table. It's the first time you'll start seeing a student kind of show aspects of what being a colleague is like, which is rare, right? How many times have you talked to a medical student, or you've talked to a resident, just thought, God, they just don't know what they're talking about? Well, that is because they haven't gotten to self-directed learning yet. They're still an involved learner. And so they're asking you questions. They're seeking that validation from you, and they're asking you for learning strategies. They want to know, how did you learn this? What was your approach to this learning? It is totally okay if one of the key educational benchmarks for you is that while you teach these skills really well, or you teach interacting with patients really well, that one of the things you're also really good at is just talking to people about your own learning process. That's totally fair. Students love that. They're looking for that from you all. And if you haven't explored that yourself, you actually might think about just getting a quick note card and thinking about, when I need to learn something new, if you're studying for your own boards or recertifications of some kind, how do you approach all of that studying? It's a lot. And I bet you all have strategies that you use, right? Even if it's just, I'm going to go out and buy a prep course. hey, that works. So what you're doing is test, retest, and recall, and you are looking at question banks to improve your own knowledge. That's a learning strategy. That is totally valid. And so our hope is by the time we send you medical students, that they're at least at level 3, moving to 4. And 4 is an actual self-directed learner, that they can do independent projects. They can do student-directed discussions where maybe a faculty member, you aren't really even needed. Like hopefully your residents are that at some point, if you have residents. Like if you think about a resident working with a medical student, right, then the resident becomes the lead. They are the faculty member, even though they are a student themselves. That's a self-directed learner. It's the instructor as an expert, a consultant, and as a monitor. And look at the difference in expectation there. If we look at stage 1, the teacher is the center of the universe. The instructor is the center of their whole world. And by the time you get to an actual self-directed learner, you are a consultant. You are just another thing that helps students engage in their learning, but you are not responsible in your mind or their mind for making sure that the learning happens. Okay, so I want to talk a little bit about what we will be doing next time we meet. So we meet again, and I think you see me in a month. It might be 2 months, but I think you see me again next month. If you see me again next month, one of the things we're going to be talking about is actually applying some of these models and theories into your actual clerkships, some of those hands-on resources. Today is more of a primer for that discussion, but I hope that you have enjoyed it. I really enjoy working with adult learners. I think you're going to have a great time working with our medical students. And I would tell you this, if during this presentation, something I said excited you about working in it with adult learners, then we've really met my expectations. However, one of the things I would also tell you is Ms. Browning and I would love to visit you sometime. So if you would like us to come out and do a workshop, or you would like a one-on-one presentation, or you'd like to do a Zoom call with just a group of your faculty, we are more than happy to do that. And you can get in contact with us really anytime. With that in mind, I want to make sure that I give you time to either ask questions or to start filling out your information so that you can claim your CME credit. So I'll switch to the next slide. If you scan this QR code, you can fill out our quick survey and our assessment for this CME credit, and you will be able to claim your credit appropriately. If you are also interested in looking at some of the resources I talked about today, if you're really interested in adult learning theories, these are the sources I used. I tried to keep them short and sweet for you all. These are kind of the foundational books. I am actually a really big fan of the Merriam and Baumgartner book, the 2020 Learning in Adulthood, a Comprehensive Guide, because it has some actual resources in there for you. Okay, so if anyone has any questions, please feel free to put them in the chat and I am happy to answer them. And if not, please feel free to claim your CME credit, and I'll see you, I think, in a month.